Sure. So there's two components when you think about keratoconus. You're thinking the first component is visual rehabilitation. So you want to think about how can we improve the vision. And the second component is to stop the progression. So you actually have to, you separate it into two scenarios, right? So cross-linking falls under the stopping progression. So with keratoconus, to stop progression, simple things that we can do is treat dry eye, get patients to stop eye rubbing. If a patient has sleep apnea or a problem, we can organise sleep studies and a CPAP machine through their physician. So these are things that we can do kind of with the GP and sleep and respiratory colleagues. Then in our clinic, we can offer cross-linking. So this is corneal cross-linking, corneal collagen cross-linking. So this is where I was talking about at the tip of the cone, those collagen fibres that are in the stroma of the cornea become weakened because of the shape of the cornea. This is a procedure whereby we basically strengthen those and freeze the cornea in time. So it doesn't reverse damage that's already done. We're just preventing future damage. So this can be divided into epithelium-on or epithelium-off cross-linking. We provide both options at our clinic. This is essentially where you're using a special chemical, so a type of vitamin B called riboflavin. And we drop that on the cornea for a period of time. And then we set that special chemical with a specific UV light. And then that basically strengthens those collagen fibers over a period of weeks to months. And then we monitor in the clinic with our scans and with our clinical exam to see if it's been effective. We offer both types. We offer skin on and skin off, and there's differences between the two. Essentially, the skin off has been around for a long time. So a lot of the traditional studies are based on skin off. So that's kind of like the gold standard. But lots of patients do opt for skin or epithelium on because it doesn't have some of the risks that removing the skin has. So when you remove the skin, you've got a slightly increased risk of infection. You've got a slightly increased risk of scarring or hazing of the cornea. And you've also got a bit more pain because the skin's being removed. So some of those things are reduced with the epithelium-on technique, but the obviously disadvantage of that is that it hasn't been around for as long. So we don't have really long-term data. So we don't know, is it as effective as epithelium-on for stopping progression? And there's been quite a few studies. There's been a large meta-analysis that Professor Watson in Sydney's done. So it looks like it probably is as effective, but we still don't have that 10, 20-year data. So I always tell my patients that they're given an option. Sometimes I'll recommend one over another for specific reasons, but we are lucky at Eagle Eyes. We have a great machine, so we can offer both options to our patients.
Okay. Well, I called it cross-linking surgery, but from the way you described it, it sounds like in some cases, like the epithelium-on option, it's quite non-invasive. So I'm not even sure that's a correct characterization.
It's definitely surgery. So we still do it we still do it in a sterile environment. We treat it as a surgery, but it's definitely less invasive for sure because we're not actually breaching the skin on the surface of the eye. But I guess you've got to just, as per everything, you've got to weigh the risks and benefits. And I give my patients the kind of papers and just the full array of information, and then we make our decision on each individual patient what we think would be best for them.
And sorry, is that something that you do at your clinics at Mossman and Penrith, or is it actually in the hospital?
We just do it at Mossman, and then also you can do it at some of the private hospitals. So, like for example, at Chatswood Private Hospital, but we do it in-house at our clinic in Mossman.
And how long does the procedure take? And is it something that's usually a day surgery? People can go home the same day?
Yeah, you go home the same day. There's different protocols, so I'm not going to get into it too much because, again, that comes down to the severity of the keratoconus and the type of treatment. But basically, originally when keratoconus was first introduced, there was a protocol called the Dresden protocol, which was the gold standard or the classic, and that used to take about an hour. But now we have accelerated versions of this protocol, so they've been tweaked with a lot of data behind them. So usually now cross-linking takes anywhere from around 20 minutes or so, 20 to 30 minutes. So it's about half the time because we use a different concentration of the chemical riboflavin, and we also use a different concentration of the UV light. So we basically have accelerated programs that make the process a lot more tolerable for the patients. So usually around 20 to 30 minutes.
Okay.